This is where the rubber hits the road. I started this entire conversation when I was a teenager and I was running and I was playing sports, and my mom said, "Hey, you got to stop all that running. Man, you're going to ruin your joints." And it just didn't seem right to me. You know, I was that same patient that comes in to me right now with that righteous indignation. I said, "No way, there's got to be some proof out there that running is good for you." And what I found was some proof that running is good for you. Great studies indicate that running increases circulation to the joints, increases cardiovascular fitness, bone density, and muscle mass. And there's all kinds of reasons that running is good for you. But unfortunately, my mom was right, and running increases injury rates. So if you compare couch sitters with runners, injury rates are going to be much different, and they're going to be more injured on the running side. The people who are playing sports are more injured. The minute you get off the couch, you're putting your joints at risk. And that's a fact. And you know, you can try and argue with it, but it's common sense and it's logical. So I think we should start from that point when we're making decisions about what to do with our lives and how to progress. Accept that risk. Accept that we're risking our joints for the other benefits and make that choice in the right direction. So any ballistic movements are going to increase your risk, right? So I do surgery on the foot and ankle. And so in the book, Born to Run, they kind of made you out to be the bad guy. And man, looking at that x-ray right there, you'd say, whew, that guy's mean. Why would he do that to anybody? There's 1, 2, 3, 4, 5, I think there's 6 screws and 3 pins in her foot. We're going to talk about that case a little bit later. But I wanted to put that in there right now to illustrate the fact that your decisions concerning your running are going to have implications later. You're taking a risk when you decide to run. You're upping the ante. You're looking for a better life. You're looking for more out of life. And in doing so, you're taking a risk. Okay? So, some things that I deal with. Poor biomechanics, flat foot. If you're a kid, what I see in kids, early symptoms of flat foot are Seaver's disease, which is a growing pain to the heel. The kids that come off the soccer field, and my kids play soccer and you see it all the time, my heels hurt and they start limping. What's wrong? My heels hurt. It's an easy thing to take care of and usually associated with flat feet. Island's disease is another apophysitis or growing pain type of problem that I see in the foot that responds well to mechanical control. Knee pain. If you're a kid or an adult and you have knee pain, well, let's start at the foot. Foot, ankle, knee, hip, or back pain that increases as you walk or run, you should have your mechanics looked at, right? It's not an injury. You didn't get in a car accident. You didn't go skydiving. You didn't fall and twist it on the football field. It's just, man, the more I stand, the more my knees hurt. Well, there may be some malalignment that's leading to arthritis or injury later on, and it just makes sense to look at that. So if you're going to up the ante, you're going to take those chances to get off the couch, take a look at your mechanics there. Midlife symptoms, plantar fasciitis, right? I see it all day. I see it, the chiropractor sees it, the therapist sees it, the naturopath sees it. I'm sure the psychologist sees it. Everybody sees plantar fasciitis. And I think that goes back to us having a weaker arch because of that age 0 to 6 thing we talked about. It really speaks to the flat surfaces, and that arch musculature is under a lot of strain, and so are the deep fascia structures on the bottom of the foot. So that's a kind of a midlife thing I see. Bunions and hammer toes. The feet, if there's an imbalance in the pull of the tendons on the inside versus on the outside, the feet change, bones drift, toes curl up, bunions develop. Nobody wants to hear that they have to have bunion surgery, but they, believe it or not, they submit to it, they beg me for it, they ask for it, and they, you know, it's a weird thing to be a guy where people come in and say, please cut into my foot and put screws in and change my foot, and I won't walk on it for 6 weeks, and I'll take 6 months off. And so it's a big deal. You don't want those things to develop. Late symptoms, osteoarthritis. That x-ray I showed you, she wasn't that late in life, but osteoarthritis, and then ruptures. As those mechanical changes happen, as that overload happens, it gets more important later in life when we don't heal as quickly, right? If you're 12, you heal up at an amazing rate. When you're 85, that rate has slowed. You don't heal up, you don't get away with as much. So from a mechanical standpoint, let's look at this carefully. This is a guy, he's a real nice kid from New York City, and he waits tables, and he can't survive without orthotics. And we've had him in orthotics for a long, long time, and he does just fine. He's got a really active job. He's super active. He likes to jog. He's moving around. But look at this foot. Look at the angle this foot takes, this heel takes. And look at how prominent the inside of his ankle is. You see how that ankle bone sticks out there. Well, you got 3 tendons that run down the inside, 2 tendons that run down the outside. These tendons are overstrained. As you make this angle, you increase the length of the course of those tendons, which puts more tension on them, overloads them. These tendons are underworked, okay? He can't wait tables. He can't do what he needs to do without some help. And that's why, as a kid, he came in and we've been taking care of him. So look at this. I mean, man, his arch is right on the ground, right? There's no question about that. Ankles collapsed to the inside, big toe here. And the kicker, wait for it, man, he's only got 4 toes. I mean, this guy just won the foot lottery, didn't he? He's got 4 toes and that flat foot, okay? So was he born to run? Is this guy excited when he hears that everybody in the world is born to run? There's no way he's born to run. There's no way he's running. There's no way he's running a marathon, okay? So look at this. And this is another thing, right? A lot of the people I talk to are just horrified. Oh my goodness, you make people wear orthotics. Why would you do that? Orthotics, they're terrible. You're the devil. Well, look at this guy. I mean, now his heel's lined up under his leg, right? So we've reduced the force here. We've added force out here. Orthotics are not a brace. They're not going to weaken your arch. They're just changing the position of the bones so that your tendons are appropriately strained. So we don't have overload here, and we don't have tendons taking a free ride out here. The joints are lined up the way they want. This is going to rotate the knee to the outside. It's going to rotate the hip. It's going to decrease the lumbar lordosis at the back, and it's going to take the strain off the entire system. Big deal. We put a piece of plastic in his shoe. If you've got any question, get the piece of plastic, put it in your shoe. If it doesn't help, then take it out. Big deal, big risk at this level, at this point when your foot's flexible and you're young and you're healthy. If this guy came in and talked to me about born to run or being born to run, or I want to run barefoot, and I do have those patients with that foot, not exactly that foot, most of them have all their toes, but with that kind of foot, they come in and they say, I want to run barefoot. I tell them the risks and we talk about it and we have a big discussion and they hate it. So let's talk about that x-ray I showed you earlier. This woman who had that fusion done was 54. 54 is not that old. All your joints should not be trashed by age 54, okay? So I like this case because it takes into consideration a bunch of things and it shows people that you have to really look at the whole picture. So here's her foot before surgery. X-rays are tough to see, but and you may not look at a lot of x-rays. But here's the simple thing. Joint space. There's space between these bones. What holds those bones apart is cartilage. There's no joint space through here. This is the joint that broke down, and we usually see that. At some level, your joints are going to break down. Some levels are going to be spared, and some are not. In her case, her entire midfoot's terrible. She was a person who, for psychological reasons, because of her situation, ran to cope with a bad situation. Her doctors kept her going for a long, long time with narcotics, and she ran, okay? So here she is. Look at that. There's no joint space there. Complete collapse here. You don't have to be a foot doctor to see that. Complete collapse in here. This joint looks all right. These guys look fine. And we did a lot of studies and a lot of tests, and we found out which joints were upset. And she's in terrible, terrible pain. Can't survive without narcotics at this point. Okay? So before this surgery, the weekend before this surgery, and this was a very emotional process, by the way, for her, she ran a marathon. She went out and she loaded up on her drugs and she ran that marathon because that's the way she dealt with life. And so, again, terrible guy, I'm an awful guy, but she begged me to do this, right? I fused all these joints and it feels a ton better. Those bone-on-bone joints hurt. When you take them away, it does a great job of relieving the pain. You don't lose a lot in cases like this. It's not a hard decision to make as a surgeon because those joints without cartilage, they didn't move anyway. So she already had a stiff foot, stiff, flat foot, and she was working on her knees and her hips and her back. So we've normalized her mechanics. We've moved them towards normal. They're not normal, but they're more normal now than they were before because she was in such pain, and she's off the narcotics, and she's back on track. So there are a bunch of factors. She had a genetic predisposition that included flat foot. Parents were flat-footed. She was flat-footed from a young age. She had a psychological problem, an ability to disengage from the running. She also had issues that kept her in a situation that wasn't ideal. So all of those things added up to, man, I wore all my cartilage away. And those are the things these are the decisions you're trying to make right now. What should I do that's going to keep me running, keep me moving, and not keep me from having that kind of surgery? So I think that this is an important discussion to have for anybody. This, I'm sorry, it's a little gross. It's a gross picture, but this is something I see every day. That last one was extreme, and you could say, well, that's a super extreme case, and no. I see this every day, all day long. Look at this. This is a big toe joint. Sorry, the foot's up here, the toe's down here, big spur here, big spur here. This yellow stuff right here is upset bone, bare bone. This is cartilage right in here, the white stuff, and it's been worn away. The body is taking care of itself. Right? You might look at this and go, oh, look at the body's making a bad choice. No. The body's fusing this joint. If I left this patient for another 20 years, they'd stop walking on that foot, and that joint would fuse on its own in a very painful way. Okay? So we're stepping in to change what happens there to allow the patient to run and to get away. But this is mechanically driven arthritis. And that's what I see at the end of the game. I'd rather make decisions like I talked about earlier with the kid with the orthotics, where there aren't any joints that are trashed, so we're not putting screws in things, we're not opening up big, ugly joints.